Hello everybody, this is Carlos from Amir Nurses and welcome to another video. Today we're going to continue our pharmacology series with case number 2. As always, please ensure you do your 3 checks and your 10 rights prior to medication administration to ensure safety of the patient. Now our case is patient number 2. It's a 62-year-old female admitted for a myocardial infarction. The patient was experiencing chest pain with radiation to the lower back. She went for a percutaneous cardiac intervention, PCI, with 1 stent inserted into the LAD. No allergies. Past medical history include hypertension, smoker for 1.5 packs a day, diabetes, and atrial fibrillation. Vital signs are temperature 36.7, pain 5 out of 10, respiratory rate 22 per minute, blood pressure 167/92, pulse is 108 irregular, and O2 sat is 97% on room air. We did an ECG, which shows atrial fibrillation with a rate between 104 to 111 with ST segment elevations on the anterior leads from V1 to V4. Her blood glucose is 12.8, and the medication that we're going to be discussing today for MAR are Nitroglycerin, Apixaban, Bisoprolol, regular insulin, Hydromorphone, and Amlodipine. So let's start with nitroglycerin spray with the brand names Nitrol or Minitran. Common uses are for angina and ischemic cardiac chest pain. It belongs to the class of nitrate and is a vasodilator. The usual auto dose is 1 to 2 sprays, with each spray is about 400 to 800 micrograms for chest pain every 3 to 5 minutes, and wait in between to see if the chest pain subsides. Usually, if the chest pain does not go away with more than 3 dosages, then further intervention needs to be done, as the nitroglycerin might not be as effective. Some of the adverse effects include hypotension due to the vasodilation, and as a result of hypotension, patients should experience dizziness and lightheadedness, headaches, flushing of the skin, diaphoresis, and decreased level of consciousness. The general mechanism of action is nitrates. They are great at reducing the preload because they cause the arteries to dilate. And as the arteries dilate, then more blood can go through because there's a wider diameter. And if more blood goes through, then there's able to restore perfusion to the cells better. Some of the nursing considerations you're going to have is perform a blood pressure check prior to each administration, check for allergies, educate the patient, and be cautious if the patient is taking other medication for blood pressure because it will drop the blood pressure significantly. Watch for orthostatic hypotension. If the patient is rapidly switching positions or getting up, the pressure might drop significantly as well. And also be cautious and avoid giving nitroglycerin to patients who are taking medications for libido enhancing, such as Viagra, Cialis, due to the risk for severe hypotension as well. Now, the next medication is Apixaban with the brand name Eliquis. The common uses for this is to prevent blood clots. It's going to prevent blood clots due to atrial fibrillation, from deep vein thrombosis, DVTs, and also from pulmonary embolism. It belongs to the class of anticoagulants, and it is a selective factor 10A inhibitor. The usual dose for an adult is between 2.5 to 5 milligrams by mouth twice a day. Some of the adverse effects, because it is a anticoagulant or a blood thinner, then bleeding, it's one of the side effects, and internal or external, and bruising because of the thinning of the blood. Now, the general mechanism of action is it blocks the clotting factor 10A, and as a result, thrombin cannot be formed, which the clotting cascade cannot be triggered. Some of the nursing considerations, again, check for allergies, patient education. Be careful that the patient has a history of bleeding disorders such as hemophilia. You're going to do blood tests and blood work to check for the patient's coagulation status to see if a dose adjustment needs to be done. Now, assessing for external bleeding visually is a little bit more straightforward, because then, especially when it comes bleeding from the gums, from IV insertion sites, or from any other medical devices insertion sites, such as your Foley catheters, hematuria. If you start to see that the urine from the Foley catheter start to become pink and red, then that is a good sign for you to know that the patient is experiencing bleeding. Now, to assess for internal bleeding, that's a little more insidious, and you're going to go with symptoms. And as a patient starts to bleed, the pressure starts to drop and the heart rate starts to go up. So you should start seeing paleness, diaphoresis, hypotension, tachycardia, weakened 3D pulses. And in your blood work, if the patient's bleeding internally, you should see a sharp drop in hemoglobin from your complete blood count. Now, the antidote for Apixaban is Andexa, and this medication will reverse blocking of the factor 10-8 if the patient overdoses or have taken too much by accident. Next medication is Bisoprolol with a brand name Concor or Monocor. The uses for this include for hypertension and atrial fibrillation. It belongs to the class of the beta-1 blockers, so it's an antagonist. The usual dose goes between 2.5 milligrams to up to 20 milligrams by mouth daily, depends on the patient, the condition, and how long they've been taking this medication. Some of the adverse effects include hypotension, low heart rate, cold extremities, headache, fatigue, and dizziness, which are all related to lower cardiac output. General mechanism of action, it blocks the beta-1 receptors in the heart. From a previous video, you can remember beta-1 heart, beta-2 lungs, right? So it's going to block the beta-1 receptors from the heart. And as a result, epinephrine cannot bind to these receptors, therefore leading to a lower heart rate and lower BP. Now, nursing considerations, you're going to check for allergies. As always, a patient education. You got to be careful if the heart rate is already borderline, let's say, in the low 60s, because it will drop it even further. Hypotension, especially if it's taken in combination with other antihypertensive medications. And careful getting the patient out of bed or doing strenuous exercises. It might potentiate orthostatic hypotension. And because a patient is beta blocked, the heart rate might not compensate and they might faint. So be careful about that. Our next medication is human insulin regular with a brand name Humulin R or Novolin G Toronto. Now, some of the common uses in this video we're going to cover mainly is going to be for hyperglycemia. However, we use insulin also for hyperkalemia, hence I put a little star here. So keep that at the back of your head because we will revisit this point again. Okay, so this belongs to the class of the insulins. It's a short-acting insulin. The usual dose is very patient-specific. Schedules, doses can range anywhere from 0 or like 0.5 or even 1 unit up to 10 plus units per dose, given subcutaneously before meals. Now, this is a scheduled insulin dose. A lot of places, they add on what we call a sliding scale on top of the scheduled insulin. Now, the sliding scale, you can look at as a correction factor, an additional insulin needed on top of what's already scheduled should the patient meet certain blood glucose levels if they're too high, for instance, okay? The adverse effects will include hypoglycemia and the symptoms associated with hypoglycemia: dizziness, lethargy, confusion, weakness. The patient might have behavior changes, agitation, and in higher dosages, it does lead to lowering of potassium, and the lower potassium can lead to hypotension and arrhythmias. So be careful about that as well. General mechanism of action, it attaches to the receptors on the cell surface, and it helps the cells uptake glucose for use and metabolism. Now, without insulin, the cells cannot use the glucose in the plasma, and therefore, that's how you sometimes see that patients have a very high blood glucose in the plasma, but then their cells are starving, and that's a very common thing when you see in DKA, in diabetes ketoacidosis. Okay, nursing consideration. Check for allergies, patient education, especially if you're teaching the patient how to self-administer insulin to themselves. It's a high-risk medication, so it requires 2 independent double checks, meaning 2 registered nurses or 2 licensed medical professionals that can do the double check for you, okay? Always perform blood glucose checks prior to administration. Since it's given subcutaneously as the most common route, you have to be able to make sure that the patient's site is okay, the injection site. But we also are able to give insulin through the IV, but never orally because it's not the insulin molecule is not stable in the stomach acids. Also, if the patient is getting steroids, like anti-inflammatory steroids, not anabolic steroids, so anti-inflammatory steroid, then it might oppose the effect of insulin because these steroids increase blood glucose in the plasma. And also alcohol, it sets the glycemic control of the body, so be careful about that as well. Now, next medication is Hydromorphone with brand name Dilaudid. Common uses, this is for pain management. It belongs to the class of opioid analgesics. The usual dose ranges between 0.5 milligrams to 2 milligrams by mouth per dose. It is also given IV, but the dose, as you can see, it goes down exponentially to 0.1 milligrams to 0.4 milligrams IV per dose. And just be careful with hydromorphone. The hydromorphone does not have a ceiling effect. That means that the more you give, the more the patient's going to experience pain relief, and the more the patient's going to be sedated and all the adverse effects that come with it. So be careful about that, because there's no ceiling limit for hydromorphone. The more you give, the more it's going to affect the patient. Which brings us to our adverse effects. Now, some of the adverse effects include sedation, confusion, nausea, respiratory depression, hypotension, constipation, urinary retention. So all of them are very severe adverse effects that you have to monitor as a nurse. The general mechanism of action, it binds to the mu receptors in the brain, and the mu receptors are our analgesic receptors in the brain, and it leads to a euphoric effect as well. But how hydromorphone works, it doesn't get rid of the pain. It just tricks your brain into thinking there's no pain. So it increases the pain threshold, which is why it brings up a concern, for dependency or addictions. Because if the drug is constantly tricking your brain into having no pain, instead of actually getting rid of the pain, then you can see how your brain chemistry can be altered over a long period of time of use. Okay, so be careful about that. Nursing considerations, we're going to check for allergies, educate the patient between addiction, tolerance, and overdose. Addiction is the patient needs to be consciously and actively seeking for the medication. Tolerance, it just means that the patient needs a higher dose to achieve the same level of outcome of pain relief. And overdose is the patient takes too much, either intentionally or unintentionally. Think about some of the adjuncts for opioids, non-pharmacological versus pharmacological opioids. So non-pharmacological adjuncts, you have things like cold and cold massage. You have imagery or distraction. Pharmacological adjuncts include other non-opioid analgesics such as Tylenol, gabapentin, etc. Now, you're going to perform a pain assessment before and after administration. You're going to monitor the vital signs, blood pressure, and your respiratory rate. If the patient is able to follow instructions, then you should advocate for a patient-controlled analgesic, which it has been shown to improve patient control of pain tighter because the patient has control over it. Some additional supporting medication you might be thinking about ahead of time would be antiemetics because of the nausea that the hydromorphone brings, and laxatives because of the constipation that's very, very common with opioid analgesics. Also, we have to be very careful when giving pain opioid medications for patients who are already taking sedatives such as benzodiazepines, because it will sedate the patient even more. If there is a case where the patient is very lethargic or unarousable after giving hydromorphone, your antidote is going to be naloxone, a brand name Narcan. And what this medication is going to do, it has a higher affinity for these mu receptors, and it's going to kick off the hydromorphone off the brain temporarily so the patient can wake up. But it's very short acting, so you might need to give that over a longer period of time. And our last medication for today is going to be Amlodipine with the brand name Norvasc. Common uses is for hypertension. It belongs to the class of the calcium channel blockers, with to be more specifically in the dihydropyridine type. Now, the usual dose is 5 to 10 milligrams by mouth daily. And some of the adverse effects include like swelling, headaches, dizziness, flushed skin, and hypotension. General mechanism of action, it blocks the calcium channels in the heart, and therefore it decreases the force of contractions. and it also relaxes the smooth muscles in the arteries, reducing your afterload. So some of the nursing considerations, again, check for allergies, patient education, monitor for BP, especially if Norvasc is given with other antihypertensive medications such as beta blockers. And the antidote for amlodipine is going to be the calcium. So calcium chloride or calcium gluconate. Both are feasible, but calcium chloride is 3 times stronger than calcium chloride. So you might want to use this with a central line, or if the patient's calcium is very, very low or hemodynamically unstable, because it will provide more calcium per shot compared to calcium gluconate. Now let's move to our analysis of the case study and applying the case studies to the medications. Now, which of the medications here do you think is going to primarily affect the hypertension, so the BP, and the pulse, the fast pulse and the atrial fibrillation, with a secondary effect in relieving chest pain? You can pause the video and I'll give you the answer in a few seconds. That's right. If you've chosen bisoprolol, then you're correct. So bisoprolol, the primary action is going to be to treat the hypertension, the high blood pressure. And because it also lowers the heart rate, it's going to help with the fast heart rate here, the fast irregular heart rate, the atrial fibrillation. And as a secondary effect, if your heart is working less strenuous, right, then it has a relieving effect on the chest pain for the patient in this case. All right. Next. Which medication will have a primary effect on hypertension and the high blood pressure, but will also have a secondary effect on relieving chest pain? You can pause that video for a few seconds and I'll give you the answer shortly. Very good. If you've chosen amlodipine, then you're correct. Amlodipine, as a calcium channel blocker, it's going to decrease the blood pressure from the patient, and it's going to be used to treat hypertension. And again, it will have a secondary effect on relieving chest pain for this patient because the heart is working less strenuous. Okay, very good. Next. Which medication will have a primary effect on relieving chest pain with a radiation to the lower back, in this case 5 out of 10, and it will have a secondary effect in lowering the blood pressure? Pause the video and I'll give you the answer in a few seconds. Very good. If you've chosen nitroglycerin, then you're correct. Nitroglycerin, as a nitrate and vasodilator, it's going to help with the coronary arteries dilate, and like we say, more blood, therefore there's better perfusion, right? So there's less ischemic pain. So we're going to use it to treat the chest pain and here, but because of the vasodilation, we should expect blood pressure to go down. So hence the secondary effect of your blood pressure should be also monitored. Excellent. Next one. So which medication is going to have a primary effect to treat atrial fibrillation? And you can see here on the ECG, atrial fibrillation on the rate of 104 to 111. But it's also going to be used as a secondary preventative method for the stent that the patient got in the left anterior descending coronary artery. You can pause the video and I'll show you the answer shortly. Very good. If you've chosen Apixaban, then you're correct. Apixaban as an anticoagulant, as an anti-factor 10A inhibitor, it's going to help with atrial fibrillation because that's one of the main dangers of atrial fibrillation is the clots that form in the atria because blood just sits there because there's no atrial kick to get rid of that extra 30% of blood. As a result, they need to be on a blood thinner so that they don't get pulmonary embolisms or strokes. Right now, you start thinking about it, it's also going to help with the stent because it is a foreign object that was just inserted. What is going to happen is the body is going to have a tendency of attaching platelets and starting to clot around it. So therefore, the patient needs to be anticoagulated. But the patient, since it's already taken Apixaban, then it's going to have a primary effect on the atrial fibrillation, but it's also going to have a secondary effect on the stent, which is 2 birds in 1 stone. Correct. Next, so which medication is going to have a primary effect on the blood glucose of 12.8 and on the history of diabetes? And pause the video and I'll show you the answer shortly. If you've chosen the normal insulin, Humulin R, then you are correct. This will help the patient lower the plasma blood glucose so that the cells are able to use the glucose and perform metabolism. Perfect. Now, which medication is going to have a primary effect on the chest pain and with radiation to a lower back? So which medication is going to decrease that? And it's going to have a secondary effect on the blood pressure and the respiratory rate. You can pause the video and I'll show you the answer shortly. Very good. If you've chosen Hydromorphone, then you're correct. Now, in this case, Hydromorphone, we're going to use it as a secondary pain reliever after the nitroglycerin for ischemic cardiac pain, because if it's a narrowing of the coronary arteries that is leading to the ischemic pain, then we always want to treat it with nitrates first. Okay, if the nitrates are ineffective, then we have to give the patient better pain relief. So in this case, the Hydromorphone is going to act as a secondary pain agent if the nitroglycerin fails, and it's going to help with the chest pain with radiation to a lower back. However, Hydromorphone is also going to lower the blood pressure and it's going to lower the respiratory rate as a secondary effect. So that's something that we have to be mindful about. Okay? And that's it for this video. Thank you for watching. Please like and subscribe and see you next video. Bye for now.